Hey, you wonderful generalists. This is another episode of The Generalist, the CCFP 105 Topics podcast. This is personality disorders. This one was written by the now well-known Shala Gunn, family med resident in Calgary, Alberta, and reviewed by the now ubiquitous Dr. Darby Awashina, an EM psychiatrist working out of Calgary as well.
So, why should a family physician learn about personality disorders? Well, to start, we're usually the first point of contact with the patients who have them, and often the first to recognize that patients have a personality disorder. While psychiatrists may have a role in their treatment, most patients do not actually require referral. Even if you do not plan on managing the personality disorder, you will have patients with personality disorders, and this podcast will help you effectively manage any challenging situation you may come across.
Personality disorders make up over 10% of the general population, which is a whopping stat, and 24% of the population in your primary care group. They might or might not seek help for aspects relevant to their personality disorder, but they sure will as well have other health conditions. Remember, they're people with bodies. They're going to have other medical concerns.
We all can remember a patient with a personality disorder. You may remember your own feelings of anger, frustration, fatigue while interacting with this patient. This is totally normal, and it's called countertransference. Unfortunately, these feelings can impact the way we interact with and treat these patients, and also all the patients afterwards. We are, in fact, human.
What? The goal of this episode is not to teach you about specific diagnostic criteria of personality disorders, but rather how to treat these patients with regards to their personality, but also their other issues. We're aiming to give you some tools to monitor your own thoughts and emotions so they don't impact the patient care. If this sounds a little bit like CBT, that's probably because it is.
Please note that this podcast will largely focus on our cluster B personality disorders, which are often the ones you're going to come across in practice and most likely to present in a crisis. So, what is a personality disorder? We all have a personality, but according to the DSM-5, it becomes a disorder when there is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to clinically significant distress or impairment.
To paint you a bit of a picture of who this person is, it's often going to be someone with difficulties with relationships. They're going to have trouble handling their emotions and their thoughts, and they're going to find it hard to understand that it's actually their behavior that's causing them troubles in life. In other words, they don't have much insight.
Put in a simpler way, personality disorders, more or less, are permanent problems of behavior and human interaction established by early adulthood that are unlikely to change throughout the life cycle.
We're going to start with a bit of a description of the different personality disorders. The full DSM-5 criteria can be found in the show notes, so head there if you want that. But personality disorders generally can be broken down into three clusters. These are the A, B, and C, and you may have heard before them referred to as mad, bad, and sad.
Our cluster A personalities include schizoid, schizotypal, and paranoid. These are the patients you might perceive as being odd or bizarre.
Classically, we might perceive these with schizoid personalities as loners. Importantly, they want to be alone. They never take a mate, they have no friends, they're not close with their family members.
Interestingly, when asked about the same, they appear as though it never occurred to them that social interactions are important.
COVID was perfect for them. These personalities might strike you as odd, eccentric, and they might have some magical thinking and ideals of reference. If this rings some bells towards schizophrenia, there's actually some genetic association between them and schizotypal personalities that may predispose.
More likely, you will encounter paranoid personalities. They may have an extreme sense of distrust and hesitancy, not just in relationships with others, but also with the medical system. They're often hesitant to trust your medical advice or opinion.
Cluster B personalities. These include narcissistic, borderline, antisocial, histrionic. These patients are the ones that'll give you some countertransference. They're known for how they make other people feel, which is sometimes why we refer to them as, quote, bad, end quote.
Narcissists need showering glory and often lack empathy, though at times they may fake empathy. Borderline personalities are known for their mood swings, feelings of emptiness, impulsivity, poor self-esteem, and splitting behaviors, which often show up as idealizing or devaluing others.
Yeah, these are these people that are going to be your best friend in the emerge and try and make the others in your team the enemy. Antisocial personalities are usually not criminals. They're likely to have had conduct disorder as a child. They have no regard for others and they don't abide by cultural norms. They can come across as superficially charming and complimentary.
And finally, histrionic personalities are seen as provocative personalities that need to be the center of attention. They can be quite dramatic in their tone of voice and seductive in their clothing choices. Does this remind you of anyone?
Schitt's Creek, right? The mom.
And Alexis, maybe even. She wrote a song about herself.
Maybe so. Yeah. Touche. Finally, there's cluster C personalities. These include obsessive compulsive, dependent, and avoidant.
You're probably familiar with these types. They are the anxious types. Obsessive compulsive personalities. This is not to be confused with obsessive compulsive disorder.
Obsessive compulsive personality disorder can be seen as egosyntonic. That means the same, where their actions and the feelings align with their thoughts.
Obsessive compulsive disorder, on the other side, is ego-dystonic, meaning distinct or different from us, where the obsessive thoughts and resulting compulsions we experience are distressing and unwanted.
It's great to clarify. Dependent personalities can be overly clingy and they need often constant reassurance.
Finally, avoidant personalities, well, they avoid. They can be thought of very similarly to social anxiety disorder, as they are often worried about other people's perceptions of themselves. At their core, they believe that they are somehow defective and often have a very difficult time letting anyone get close to them.
This differs from patients suffering with SAD, given that at their core, they can have an intact self-esteem.
Social anxiety disorder.
That only gets tested when in social situations or they're exposed to situations where they might be judged, embarrassed, or scrutinized. The patients tend to have friends and they don't avoid to the extreme extent that patients with avoidant personality disorder would.
We will explore many of the challenges in working with patients with personality disorders through a series of cases.
Case number 1, a 35-year-old woman. Friday afternoon, she shows up at the end of your clinic day. She's feeling suicidal after a roommate moved out and took their cat with them. She tells you the whole world is against her and there's no reason to be alive. She needs some Ativan from you and she thinks that'll help and goes so far as to threaten suicide if she does not get a prescription today.
What do you do? Hint, hint, check out our crisis episode.
So good. This is a pretty classic example of how a patient with borderline personality might present in a crisis. They are very challenging situations to handle.
They often present with a broad range of behaviors, such as behavioral disturbances, self-harm, suicidal ideation, suicidal gestures, impulsive aggression, and even short-lived psychotic symptoms, in addition to their intense feelings of anxiety, anger, and repression.
And often they're best handled outside the medical setting, which is unfortunate because we're always in the medical setting. Because using your doctor or the emergency room as a coping skill are pretty negatively adaptive. These patients need to learn skills to use on their own to deal with these situations, but of course during the crisis is not the time to have that conversation.
Because this is the first time she's done this for you, and because you're at your end of the day, you decide to see this patient.
Before you go see the patient or any patient who you think might be struggling with a personality disorder, take a minute before you go in the room and plan out your approach.
Number one thing to think of is setting some clear boundaries.
For instance, you're clearly going to let her know you have 15 minutes only with her.
Review the clinic policies to ensure that she does not expect special privileges in the future. For example, you might say, if this were any other time of the day, or if she had done this multiple times before, you would need to send her to the ER, as it is not appropriate to show up in the office like this.
Next, don't forget to take a deep breath.
You know how you feel when you work with patients like this.
So you remind yourself, both of you are humans, both of you have emotions, and this is going to impact on one another.
You vow to see things objectively and treat objective issues, especially because she is in crisis.
Next, have a plan for your discussion about the medication she's requesting.
If you agree to prescribe Ativan, how much? How many times per day? Having this plan ahead of time minimizes the chances that the patient may sway or try to convince you to prescribe more.
For Ativan, a good rule of thumb is very short term, that is like less than a week, 1 milligram per day, PRN, and reiterate that it's only for situations where the behavioral interventions failed to reduce her distress. For example, it's not the first go-to when she has a little bit of agitation.
Anticipate her asking for other medications when she hears your boundaries. For instance, no, you will not prescribe any other sedating agents.
Yeah.
No fentanyl today, no ketamine.
As with any patient, make sure that you feel safe and that the others in your office feel safe as well. Make sure you're not alone there and there's no one to supervise. Then conduct the interview with the door open, making sure there's a clear exit for both of you if that's possible. If you feel unsafe, leave or call security if you can. Now that you've set the boundaries and you've established your safety, how do we go about doing this?
Be mindful of your own feelings and maintain a calm, non-threatening attitude. Remember, the patient is feeling how they are feeling. Don't minimize this and try to understand it from their own perspective.
Borderline personality has an estimated 10% suicide rate. You have to take these crises serious and eventually help your patient develop more appropriate coping strategies. You need to help them build their toolbox or find them someone who can.
Unfortunately, many patients who are not taken seriously tend to induce complacency in the assessor, especially when they're seen over and over again. A part of the disorder can be black and white thinking.
In a crisis, you can't rationalize with an emotional mind, even though you may find yourself trying to. Well, that's kind of what we do. This can be a difficult skill to learn.
It is important to perform a suicide assessment, knowing how high the suicide rate can be. This can be challenging, especially because suicide cannot be predicted. It is important to ask about intent, access, preparation, and ensure you document any past attempts. A patient with a past attempt by overdosing on Ativan is going to change or influence your management, particularly if you are prescribing it to them.
Yeah, probably so. So fentanyl then instead. Ask what they are living for. Depending on how well you know the patient, come up with your suicide risk assessment. Of course, you can't predict suicide, but those with more protective factors have a better prognosis. Emphasize the positives in their life. That can help them feel more hopeful.
It's important to balance the person's other comorbidities, such as depression, their borderline personality disorder, and the current stressor into this.
If you think the risk of suicide is high or you have any doubts, to be honest, you need to call 911. You can certify a patient from the clinic. In Alberta, for example, this involves completing a Form 1 that ensures they are conveyed to a hospital for further assessment. If they're not high risk, keep talking.
It's also important to remember to document everything in case something does happen. You showed that you did a very thorough assessment. Then it's important to work on de-escalation. Listen to your patient without too much interruption. Validate their emotions, but not necessarily their actions. Let them get their feelings out and ensure that they feel safe to do so.
One way to support them in this crisis could be to ask small, manageable questions. These big open-ended questions that we were taught in med school, like how can I help or what happened, can be big and daunting in this situation. Instead, things like how long have you been feeling this way? Do you know why you're feeling like this? These might be more approachable.
It may be easier for the patient to speak as they get going. Sometimes all people need is a chance to vent and feel connected and like someone's listening. What they don't need is you to provide all the solutions to their problems.
This is very familiar. Foster their autonomy, foster their choice, but also realize when acute intervention is or isn't needed. That we can be quick to admit these patients when realistically rapid hospital admission can prevent the person from developing the coping skills they need. It can also foster an inappropriate dependency on having others like the medical system solve their problems for them.
At this point, your patient may go one of two ways. They calm down. Fantastic. We'll move on to the next step in a moment.
Or they keep escalating. There's little evidence for the benefit of medications in these situations, so do try to stay away from the benzos if you can.
It may be appropriate to prescribe when there is a concern of self-harm or violence, but these patients really should be sent to emergency. Consider the chances of alcohol or illicit drugs being on board, and consider how this will change your relationship with the patient in the future.
For example, is this going to hinder their ability to form good coping strategies, which is what they ultimately need? Are they going to expect this from you every time they have another crisis? And if you do decide to prescribe, only provide one prescription at a time.
Just to emphasize, like we did before, make it a short prescription, limited time, maximum 1 week, and always consider what a lethal dose would be and try not to prescribe an amount that would be lethal if they took it in an overdose attempt. They need to know about this. It is only one tool in their eventual toolbox that the patient will be provided with skills that they learn in the future. Tell them why it is so short and that this is non-negotiable.
If you can't stop the drug within 1 week, ensure you monitor closely and document the effectiveness, the side effects, the misuse, and any signs of dependency.
For any of these above scenarios, make sure you do the following. Book a follow-up appointment. Book it now and book it soon. Ensure that the patient knows. This will make them feel seen, heard, and validated, knowing that you care.
It is critical to have scheduled follow-up with these folks. It gives them certainty that they're going to see you again, which in and of itself is helpful to prevent these crises from escalating. It's a tool to help patients work at keeping themselves safe, but remember, we can't predict or 100% confidently ensure that they are safe, but often doing this can prevent them from showing up in an unsolicited basis.
And finally, tell them that it's inappropriate for them to show up whenever they need, but you're happy to book a weekly appointment with them. If something happens between weekly appointments, develop a management plan for them. We'll discuss this later.
Case 1, Part 2. Your patient returns and is not in crisis. She apologizes about what happened last week, thanks you for your patience with her. She does not understand why she gets this way. No one else in her life seems to react the way she does. Awesome. So you made it through managing the first crisis successfully, it seems like. Now it's Tuesday. You booked your patient in as the last patient of the day, just in case there's strong countertransference. You don't want to set yourself up for a rough day.
So what are the risk factors for borderline personality disorder?
Like everything, it's complex. There's genetic and environmental factors. People are born with inherent personality and temperament, which are often shaped by experiences. So the usual mix of who knows what.
Research has shown that there are certain areas of the brain related to impulsive behavior, emotional instability, and the way people perceive events. The incidence of borderline personality disorder is increased in families with other related mental health conditions. It is more common in females than males.
Environmental factors that can contribute to the development of borderline personality disorder include things like separation, neglect, abuse, or other traumatic child events, the ACEs. Unfortunately, many of these folks will have a history of PTSD that can stem from childhood trauma like abuse, which is unfortunately often sexual.
Shout out to our counseling episode, which may help you manage some of these other issues.
Now, both you and your patient are likely going to agree on at least one thing, that we all want to avoid another crisis. How do we help the patient do this?
Both you and the patient will likely agree on at least one thing. We want to avoid another crisis. How will the patient do this?
First, if the patient meets criteria for borderline personality disorder, share that with them. It's a diagnosis. Oftentimes we're afraid that the patient might reject it and it could impact your rapport, so we try to treat them without actually naming what they're struggling with.
When we take the time to educate the patient on the diagnosis, we give them something to understand as a diagnosis that we can move on to discussions about management and treatment together from the same place of understanding.
So take time to reflect on the last crisis. What happened? Where were they? Who were they with? Were there signs that told them that there was a crisis about to hit?
Some in-office counseling can be effective. However, a more rigorous outpatient dialectical behavior therapy is the gold standard, especially for a patient that is appropriately help-seeking. Dialectical behavior therapy is similar to cognitive behavioral therapy and mindfulness.
It's got 4 domains, including
emotional regulation,
interpersonal effectiveness,
mindfulness,
oh, we know this one very well, and distress tolerance.
If the patient cannot get into treatment like this soon, you can work on some skills in the office or refer them to a book, which we'll link in the show notes below.
Tons of good books. Awesome way to get them involved in their own care. The Dialectic Behavioral Therapy Skills Training Manual, written by Marsha Linehan, is linked in the show notes. We've also linked some websites that you can refer your patients to with DBT skills, which is awesome because good luck finding somebody that can do CBT or DBT for them.
It is important to make a crisis management plan with the patient. This involves filling out a contract between the patient that outlines previous crisis duration, frequency, triggers, and behaviors during that crisis.
It reminds me of like the asthma self-care crisis guide to identify when it's getting worse and when you need treatment. It seems to work there. It should work here too. It also elaborates on safety concerns like self-harm, suicidality, or safety for others, and plans who the person is going to contact during a crisis, both within and without the house, with a planned response. There's a section for indications for admission.
For various situations, there is clearly outlined intervention for response. This should be filled out with the patient and ideally someone else who is close to them, such as a parent, partner, or friend. They should all have a copy so that at least somebody knows what to do in that situation.
So we've linked a template you might consider using. Check out the show notes. Once you and the patient have completed that plan, encourage them to hang it somewhere visible that they're going to see every day, and reiterate that the plan will work if the patient works with it.
Medications can be helpful, but they're not the mainstay of treatment. They can be used to treat some of the comorbid disorders such as anxiety and depression, or for certain symptom clusters. Use them judiciously and try your best to avoid polypharmacy.
For example, if a patient's prominent symptoms are depression, interpersonal sensitivity, impulsivity, and aggression, maybe the SSRIs are going to help. You could use them first line with the most evidence for sertraline, up to 200 milligrams a day. A mood stabilizer could be used to augment as well, depending on the clinical situation.
If the prominent symptoms are mood lability, impulsivity, aggressiveness, and if there's a family history of bipolar disorder, mood stabilizers can be effective. These would include valproic acid, carbamazepine, or lithium, which are first line. Similarly, an SSRI can be used to augment this.
Finally, if the most prominent symptoms in this personality disorder are paranoia, psychotism, hostility, and anxiety, you can think of starting with an atypical antipsychotic like quetiapine. Doses for this would be less than you would use with schizophrenia. This can also be augmented, again, with an SSRI or a mood stabilizer, depending.
So to summarize that, essentially, sertraline, mood stabilizers, and atypical antipsychotics are some of the medications you can consider, but do your best to avoid polypharmacy and continue to reassess the medications. If you're considering medication augmentation with antipsychotics, it may be best to get a psychiatry consult for the management of this. Always remember, in patients with impulsivity, especially those with a history of overdose attempts, weekly prescribing may be necessary.
And of course, always remember to treat comorbid psychiatric disorders. They're humans that can have multiple things going on.
Common comorbidities for a borderline personality disorder include
depression, of course,
anxiety,
eating disorders,
addiction,
and suicidality.
Of course, treating the borderline personality disorder can alleviate many of these conditions, but other medications and counseling may also be helpful. Please refer to all of our other relevant podcasts, including depression, anxiety, and eating disorders, for more on that.
Case number 2. You were just referred a new patient by a colleague. There's a big red flag in the chart in red. Antisocial personality, beware. How to approach this case?
Well, first, you do get some shivers down your spine and start panic thinking about the interaction that is to come. All the preconceived assumptions of this patient cross your mind. They must be a criminal. They probably use drugs. They will be abusive to me.
All of this is coming back to me. So allow these thoughts to pass, but again, take a deep breath. Assess this for yourself. Not every patient labeled with personality disorder actually has a personality disorder to begin with.
Maybe the other physician had a poor relationship with this patient, or maybe that physician had a personality disorder themselves.
Oh, snappo! Maybe it was a label they were given in their teen years and then it just followed them around.
These labels have big repercussions and should not be used lightly. Think about the way you felt when you heard this. If this is not accurate, it's important that the patients are not seeing doctors who already have a negative attitude towards them before even meeting them.
So true. Before you give someone the label of personality disorder, it's important to consider other differentials that could be contributing. We talked about before, personality disorders are long-standing and pervasive.
They should not be suspected if there's a sudden shift in character. Instead, consider an adjustment reaction, especially if the patient has recently experienced a life-altering event such as the loss of a loved one or is a new partner. Consider other psychiatric mood or anxiety disorders.
It's so true, man. Like, think if you've been living on the street for 20 years, you're probably not going to fit personality-wise with people who have lived their whole lives in a suburbia. And in keeping with that, substance use is another important consideration for what these patients might be suffering from.
Neurological disorders may present with character shifts, for example, if there was a recent stroke or traumatic brain injury involving frontotemporal lobes. Consider imaging in these patients if the history is suggestive of this or if they're over 50 years old.
And consider what meds they're using. Similar to substance use, there's certain meds like stimulants or steroids that can alter aspects of a person's behavior.
Finally, consider medical disorders. Similar to when you begin the workup for a patient with a mood or anxiety disorder, it's important to rule out simple reversible causes, including thyroid dysfunction, arrhythmias, diabetes, hypoglycemia. Consider ordering ECGs, complete blood counts, electrolytes, TSH, and their glucose and hemoglobin A1C.
So we weren't able to cover much regarding the treatment and diagnosis of cluster A and cluster C, but
in brief, cluster A personalities are challenging because they often don't want to change. However, due to the relationship with schizophrenia, it is believed that the dopaminergic pathway may be involved. Thus, there is some evidence that antipsychotics such as risperidone may be helpful in patients seeking treatment.
Cluster A, antipsychotics. Ultimately, maintain a professional stance, give them clear explanations and rationales for your diagnosis, avoid over-involvement of social and personal issues, tolerate any behaviors you might think are odd as long as they're not harmful, and paranoid patients might need extra reassurance and they might need some more evidence than others might need.
Cluster C personalities have a lot of overlap with anxiety disorders and thus can be treated as such. Reassurance, reassurance, reassurance. Validation is important. Be thorough, especially for those with obsessive compulsive personality disorder. Cognitive behavioral therapy can be beneficial for these patients, and often they do express interest in changing.
We did include the AAFP's personality disorder article in the show notes. It has some great tables that outline the treatment of each of these conditions.
All right, man, you've had a heck of a week, but you're proud about the way that you've handled all these challenging situations.
Case 3, 23-year-old female named Sarah. History of eating disorder and self-harm, in addition to a significantly traumatic childhood.
Fortunately, together, you recognize these early, and she put the hard work in to change by attending a year of dialectical behavior therapy. She has been quite well for 2 years, but presents as downcast and tearful today.
Your first thought is that the DBT didn't work, but then you remind yourself the risk factors for personality disorder are very similar to those of depression, and often they co-occur.
In fact, they should commonly be screened for, as 83% of those with borderline personality disorders also report depression. It is also important to remember that schizotypal personality disorders have genetic similarities to schizophrenia, and this should continue to be monitored for.
But it can be difficult to distinguish between mood disorders and personality disorders. They often both have dysregulation of their emotions. For example, borderline personality might have chronic suicidality and self-harming behaviors. Those with avoidant personalities might have socially anxious tendencies.
Why is it so important to differentiate between personality disorders and mood disorders anyways?
A fine question. It's because the treatment's going to change. Meds aren't going to change someone's personality, but they could help the way they feel. Personality disorders are most effectively treated through psychotherapy, talk therapy. If personalities are mislabeled as mood disorders, they might not even get to the psychotherapy that's going to be most helpful for them.
However, if those with personality disorders also have an unrecognized mood disorder, they may not receive the quality of life improving medication.
Touché. So how do we tell if it's personality or a comorbid mood disorder?
The short and sad answer is there is no good way.
No! Oh, but the long answer is careful assessment and sometimes trial and error.
Through careful assessment and sometimes trial and error, you may be able to differentiate them.
Using borderline personality disorder as an example, the depressive symptoms occurring as a part of the borderline personality are often transient and related to interpersonal stress. These quickly resolve once the stress is gone.
The depression is often a result of maladaptive ways they communicate their dissatisfaction with the situation. Antidepressants won't fix this. Major depressive disorder requires a person to meet the DSM-5 criteria for major depressive disorder, including these feelings being present for 2 or more weeks.
And as we talked about before, another differentiating factor is the time course. Personality disorders, they're pervasive and they're longitudinal. Mood disorders can be chronic, but honestly, they usually have some episodic nature. So remember, get collateral with the patient's content because patients and family might be able to better tell you if this is a change from their baseline.
Ultimately, there's a fine line between the two, and sometimes it's easier to differentiate them in some people than it is in others. Always resort back to the DSM-5 criteria when you're stuck. Also, remember, we treat patients, not a diagnosis.
The NICE clinical guidelines suggest that people with a personality disorder should not use medication specifically for the borderline personality or individual symptoms associated with it.
However, as we mentioned above, they suggest pharmacologic treatment may reduce the symptoms, things like the anger, anxiety, depression, hostility, and impulsivity. In addition to what we mentioned above, we will link the CANMAT guidelines for treating concurrent personality and mood disorders in the show notes.
You might remember those from previous episodes too. They're very good, very thorough. If you think your patient has both a personality disorder and an overlying mood disorder, then feel comfortable treating both. Remember, the personality disorder might make treatment of the mood disorders more complicated, partially because it's tough to get a good therapeutic alliance, as well as more difficult to get adherence to the treatment for self-harm and substance use under control.
At this time, there are no clear guidelines on whether a sequential or concurrent approach is better, so work with the patient, figure out what's best for them. Refer to our episodes, as we mentioned above, on anxiety, depression to learn more about the diagnosis and treatment of these comorbidities.
Swinging back to the case, you feel pretty lucky that you have known Sarah for so long. You've seen her improve so much, and so you have enough data to recognize that this is a change from her baseline. You learned that she's felt this way on and off for the past 5 months since you graduated, so for up to 3 weeks at a time. And she's been looking for a job and not having much luck. She knows this is normal. She feels guilty every day about it though, and she feels like she's not doing enough.
This is starting to impact her sleep. She's lost 10 pounds. She's not able to eat. She doesn't feel suicidal, but she does admit her mood is very low, and she expresses no interest in her usual activities that she used to enjoy. You are happy to find out she still has regular appointments with her counselor.
So you talk about some lifestyle changes she can make. You learn she's done her best to implement them because she learned them before in therapy, and you decide together to start her on an SSRI. After 2 months, she comes back, she thanks you. She still hasn't found a job, but she's much more motivated to look for one. Okay, that's a net positive.
And that's all, folks.
I mean, they're challenging. They can pose challenges in how you establish that alliance. Your own personality can affect the way the patient acts, vice versa. So keep the big picture in mind. Keep in mind what they're there for. Stay calm, set boundaries. And if this isn't another sales feature for longitudinal relationships, especially that last case, I don't know what is. She's fortunate to have a family doc, and we're fortunate to be family docs.
Clearly, we've got lots of other podcast episodes that are very relevant to this one. Just to summarize, we've got anxiety, depression, we've got our eating disorder, we have our counseling, and we have crisis episodes to look forward to. Thanks
to you for writing this. You're incredible. And thanks again to Dr. Darby Iwashina. You are wonderful. We really appreciate your input. Thank you. Check her out at doc.darbs on Instagram. All right. Goodbye, everybody. Thanks for listening.
Bye-bye.